I now have the distinct pleasure to introduce Dr. Scott North. Dr. North is a medical oncologist at the Cross Cancer Institute in Edmonton, Alberta, and has a clinical practice limited to genitourinary oncology, prostate, bladder, testicular, and kidney cancer. At the present time, he's also the acting division director of the Division of Medical Oncology at the Department of Oncology at the University of Alberta. We've been privileged to have Dr. Scott North as well as our director, our chair of our medical advisory board for the last 2 years here at Kidney Cancer Canada, and we greatly appreciate the role that you've served in that regard. Dr. North is going to enlighten us today on the basics of kidney cancer with his talk, Kidney Cancer 101. And just for those of you in the room, you may notice that in your packages you've had some question cards and they're on the table as well. So please jot down your questions because we will be bringing the panelists up before lunch from the morning session, so you'll have a chance to have some of those questions addressed, and we'll be picking them up the room. So thank you, Dr. North.
All right. Well, thank you very much for the kind invitation to come and spend some time with you. What a tough act to follow. I will try to do my best to do some general overview of kidney cancer. And again, what a lovely place to come instead of being at -14 in Edmonton as it was yesterday morning with snow all over the ground. So I was asked to cover some very broad concepts about kidney cancer. I'm not going to talk about specifics of any kind of treatments or surgery, radiation, or drug therapy, but just to sort of set the stage. Because as Deb so importantly noted, we are a wide audience here. We've got the newbies, as she says, and we've got the veterans. And so I'm sure that when all of you entered into the healthcare system dealing with this, it was a whole new world, a bunch of different terminology, language, and confusion. And then you go to the internet. And so what I just want to do is hit the highlights of some of the broad-based concepts, and then again you've got your question cards if there are specifics about anything that I haven't covered that you want to review. So I'm going to talk about what actually kidney cancer is and what do we know about what causes it. What are the symptoms and signs? So what might you see or what might somebody detect? And then what are the tests that we have available for determining if a person does or doesn't have kidney cancer, and then talk about the different types of cancer. Because cancer is a real broad term that encompasses a whole bunch of different kinds of problems. And then one thing that we hear a lot about are genetics and inherited cancers. And so what we do need to know is, all right, thanks. Why would my cancer potentially be something that could be inherited in the family versus maybe just something that happened to me? And then I want to also talk a little bit about complementary therapy, because we know that many of the people in the room and in our practices as clinicians are taking other complementary or alternative therapies. So if you had to define what cancer was, even in the medical community, we had a real hard time coming to a concise definition about what cancer is. We have a lot of terms. We throw a lot of language around, and we tend to muddy the waters when we do that. One of the things that people see in the literature is the word neoplasia. Well, neoplasia simply means something new is growing. It doesn't necessarily mean it's cancer. And if you actually hear people throw the word tumor around all the time, tumor, if you look at what that means literally in English, just means swelling. So we throw all these words around, but it doesn't necessarily define what cancer is. But what cancer really boils down to is just a situation of uncoordinated growth. So all of the cells in your body have to grow and change, and they have to adapt to stress. And they do that in a very controlled manner. And so what happens in cancer is that the balance of power is shifted. And instead of having things tightly controlled between growth and no growth, everything spirals out of control. And what causes that problem in any particular part of our body is the mystery. And we have some ideas about what can happen both from a genetic perspective and from lifestyle choices, but what I will do is sort of highlight some of those genetic differences later. So basically, cancer is just uncontrolled growth. And depending upon what cell in the body that starts in, and in our case, we're interested in the kidney, what that cell will do is start to divide. And one cell becomes 2, and 2 become 4. But it doesn't respect the normal rules of engagement for why a cell should grow or stop growing. And so then what it does is it starts to get bigger and bigger and push into areas where it doesn't belong. It doesn't respect its neighbors. And as cancers get bigger and bigger, they'll start to push the normal guy aside. And if they have the opportunity, given enough time, they'll actually try to travel throughout the body and go to different locations. And that's when we talk about the technical term of metastasis. Now, we have to be a little bit careful that we don't lump all of the different types of cancer in the kidney together. The kidney, like any other organ in the body, is susceptible to the development of a number of different types of cancer within it. So when we're talking about kidney cancer, most of the time what we're referring to is this condition called RCC, or renal cell carcinoma. There are other types of cancers that can develop in the kidney, and they're more related to bladder cancer, or you can develop different kinds of blood-based cancers in your kidney, like lymphomas. We're not talking about those. So we need to be clear that whenever we're thinking about the topic and looking at things in terms of reading pamphlets, literature, whatever, we're talking about RCC. And these cancers typically will start towards the edges of the kidney, either on the top or the bottom, which are called the poles of the kidney. So here you've got a tumor that is more towards the bottom of the kidney. And this is where we'll talk later on about surgical management of these things, that if they're on the ends of the kidney, that gives opportunities for how that might be treated differently than if it was in the middle, for example. So as we have learned just from the top Debke, at first she thought she was the only one in the world that had this cancer. This isn't the most prevalent cancer that's out there. So we're not talking about breast or prostate where there's thousands and thousands of people. And that's part of the reason why we have to make sure that we get the word out and we work together. So this is a cancer that affects approximately 2% of all the cancers that are out there. So if you look at all the adults in Canada that are going to have cancer, about 2% of them have an RCC. And that translates into the Canadian Cancer Society's estimates for calendar year 2012 of around 5,000 individuals who will be diagnosed. Smoking has been linked as a risk factor, but it certainly isn't the same kind of risk factor as you might think of smoking with lung cancer. So the linkages there aren't quite as strong as they might be with other cancers. And there are some genetic conditions that may predispose to the development of kidney cancer, but these actually represent a very small minority. And so most individuals who develop kidney cancer, unfortunately, have just had it happen because of bad luck. One of the conditions which we do talk about and which the urologists have known for years is this disease called von Hippel-Lindau syndrome. And I'm going to talk briefly about that in a moment, just in the context of how the genes work that might separate out sporadic versus inherited cancers. But again, we're only talking maybe about 5% of all of the RCC that we have diagnosed as being a genetic component. Now, what about symptoms? Oftentimes, people are entirely asymptomatic. They had no clue that anything was going on and that they were developing a kidney cancer. And so something else happens that is totally unrelated, and then you end up undergoing testing for that other cause, and you find out, oh my goodness, there's something on the kidney. Classic story that we all hear is that somebody gets abdominal pain, their doctor thinks they've got gallstones, they're set for an ultrasound. Well, you don't have gallstones, but you do have a lump on your kidney that looks to be malignant. So most people are being diagnosed incidentally. However, people do have blood in their urine as a sign, and if that happens, then it needs to be investigated. And if these cancers do grow bigger and bigger, some people may eventually actually have some pain that could be in their flank, in the back, or potentially, if it's large enough, they could actually have a lump that you might be able to feel in the abdomen. But again, the vast majority of our people being diagnosed these days are diagnosed early and by accident. If the cancer does spread, it can spread to other organs in the body, and the lung is one of the most common places where it can go. So, for example, if the cancer was affecting the lung and it was causing a person to have an irritated lung, they could cough or maybe cough up blood. But again, the vast majority of people were catching these early. Making the diagnosis, once you've established that there's an issue on either an incidental scan or a person being investigated because they're passing blood in their urine, they will then usually go on to have an ultrasound or a CT if that has not already been performed. And once you have that scan performed, you will then be referred on most likely to a urologist right away. So primary care physicians may see these things on scans and then they refer them off. There are no specific blood tests that we can do that can tell you whether or not what you're seeing on that scan is really a kidney cancer or some other kind of a cancer that isn't RCC or benign. So unfortunately, unlike some cancers where we rely on some blood markers, we don't have a good blood marker either for diagnosis or for follow-up of people who have been diagnosed with RCC. Now, sometimes if we're uncertain or if we're deciding on whether or not we're going to watch and wait rather than intervene, we may do a biopsy and try to determine exactly what kind of cancer that is. But oftentimes, if it looks as though that this is very classically a renal cell carcinoma that needs to be dealt with, some people will forego the biopsy and proceed immediately to surgery. So you might ask yourself, why would I let somebody take my kidney out if they didn't tell me for sure that I had cancer ahead of time? Why didn't I get that biopsy? And I just want to show you a CAT scan and one with a cancer so that you can see how these things look. So this is a normal CAT scan. This big thing here is the liver, and then you've got the two kidneys. And obviously they're the same. You've got the same kidney tissue on each side, and you can look at this if you're a radiologist and you can be confident that that looks completely normal. What happens is you can now see this is a person who's got a very different looking kidney on the right side compared to the left side. So I'm not a radiologist, but I can look at that, and the first thing I see is they don't look the same. You know, which one of these just doesn't belong? You know, Sesame Street was right. And so that mass there clearly looks abnormal. And a radiologist can look at that and can say, that's a renal cell carcinoma. And they have a very characteristic appearance. But sometimes you may not know for sure. You may just know that something's wrong here. It doesn't look the same left and right. And that may be when you need a biopsy to confirm what it is that you're facing. So why don't we screen people? You know, a lot of people, when this has happened to them and they've got this tumor or this cancer in their kidney and they've had to have their kidney removed, they will often ask the question, well, why didn't we do some testing ahead of time to try to find this when it was smaller or when it was earlier? Maybe that would have made a difference in terms of what kind of treatment I might have needed, or maybe what kind of outcome I'm going to have. And we do know that for some kinds of cancers, there are really good research studies that have been done that show that if you take an individual who has no problems and do a test, you can diagnose a cancer earlier and make a positive impact. And mammography for breast cancer is such an example. But for kidney cancer, for RCC, we have never shown that any kind of routine testing in that regard has made a difference. It's partly related to the fact that we also have to look at resource availability. It would be impossible to ultrasound everybody in the country once every couple of years. We can't sometimes get people in for ultrasounds when they have problems that we need to investigate. But that being said, it's not been shown in any kind of research that doing routine tests on individuals makes a difference. So if a person is felt to have a sporadic kidney cancer and we don't really have a strong reason to be suspicious that it's a genetic thing in your family, we wouldn't normally be recommending that every family member in that particular situation be going for testing. And so if you look at any of the international guidelines about what to do for the routine population, they don't recommend routine testing for the average person. Now, what's the next step? So you've gone for that ultrasound for what you thought was a gallstone, and the doctor said, no, it's not a gallstone, but you do have a kidney cancer. What's going to happen at this point? Well, usually, and we're going to go on to a surgical intervention as the next step, and I'm not going to talk about any of that. But once that cancer has been removed, then we have to look at all of the rest of the information that we need to put together to put a comprehensive package of information for each person, so that we can put together an appropriate plan of action, whether that means that further treatment might be required or not. And in order to do that, we need to have information. And that information that I'm going to talk about is what's down here. And you'll hear these terms all the time if you haven't already. Histology, stage, and grade. So what does that all mean? Histology is the technical term for being able to figure out exactly what kind of cancer was in the kidney. So as I mentioned, we talk about this as renal cell carcinoma as opposed to other kinds of cancer in the kidney. But renal cell carcinoma can also be broken down into a number of different subtypes, which have different behavior, different risks of recurrence, different potential treatment requirements. And so you do need to make sure that you know what your histology is. And I'm always amazed and interested when people come to see me, and perhaps their surgery was 3-4 years ago, and you ask them that question, they don't know, because they don't know to ask. And so that's part of why we're here, is to make sure that we know we're supposed to ask these questions. So just because your cancer was in the kidney doesn't mean that they're all the same. Now, we do know that the vast majority of kidney cancers are going to be a clear cell carcinoma. That's the technical term that the pathologist will give when he or she looks at that cancer under the microscope. But there are other types of kidney cancers. There are papillary cancers, of which there are a couple of subtypes, and then others, much less common cancers, such as chromophobe and oncocytoma. I put the names up there just to show you what the variety is that we have. And here's a picture, and I'm not a pathologist, and I'm not here to go through all the distinct pictures and what is what. All I put the picture up here for to show you is these are all people who on paper were told they have renal cell carcinoma. But as a pathologist, all of these cancers look incredibly different under the microscope. So if you don't know what kind of cancer it is that you're dealing with, you're not necessarily going to be able to put together the optimal treatment plan. So histology is really important because as a clinician, it may color very much the kinds of discussions I will have with people and the kinds of treatments that potentially they would be offered. The other thing is that they are also associated with different genetic abnormalities, which might mean that there are different types of treatment that could target those abnormalities. So we are getting a lot smarter about our kidney cancer knowledge these days as we've learned a whole lot more about the genetics of these tumors and figure out better treatment options for the type of cancer that you have. So I hope you could appreciate that from that picture, those things looked very, very different. And their behavior and their responsiveness to treatments will vary, and that's why it's really important to know what kind of cancer it is that you're dealing with. And it's why it's important to have a pathologist who also is comfortable with reviewing these kinds of pathology slides. So we want to make sure that when you get that report, and I get the report back on my patient, I'm confident that the person who looked at it knew what they were doing. And so that's why we tend to send these kidney tumors to our local reference pathologists who do a lot of this work. Now, the next term that you'll hear thrown around is the word grade. And grade is a term that talks about how fast a cancer is growing under the microscope. In general terms, any cancer will be given a grade, and different systems may be grade 1 to 3, 1 to 4. They're all sort of tailored for the cancer. Generally speaking, though, the higher the number, the faster something is growing. So if you have a person with a kidney cancer that's grade 1 and another person with a kidney cancer grade 3, it generally means that the aggressiveness or the growth rate of that grade 3 cancer is probably going to be more than the grade 1. So we'll think about these kinds of things when we're putting together estimates of risks of recurrence, or possibly when we're looking at whether or not people might benefit from participation in clinical research studies to help them reduce the risks of recurrence if we think their cancer might be a bit of a worse actor. The grading system is named after somebody named Furman, so that's what you'll see on reports or when you're reading information on the net about the Furman grading system. But it is a bit subjective, so just like that picture of those different cancers I showed you, you could pass that particular biopsy sample to 4 different pathologists and you might not get 100% unanimous opinion about what grade it is. And that's why we do like to make sure that people who review these slides are doing it all the time, because they've got a sense of consistency about what it is that they're looking at. Stage is the other term that we talk about, and stage basically means how much cancer is present. And we have developed a number of different systems over the years as physicians to try to make sure that we're all talking the same language, and in making sure that we're all talking the same language, the systems of staging have gotten very complicated. So the one that we tend to use most is what's called the TNM system, which refers to how big is the tumor. Is it in the lymph nodes? That's the N. And did it metastasize? Overall, though, people usually refer to stage as a conglomerate of all of that, and we talk about stage 1, 2, 3, or 4. And stage 4 is the stage that refers to people whose cancers have spread beyond the kidney into different or distant organs in the body. So just a quick word on inherited versus sporadic cancers, because I think that, in talking to some of my patients, they're obviously concerned about their own situation, but they're also very concerned about whether or not their kids are at risk. Is this something that I have to be concerned about for other people in the family? And as I mentioned, most RCCs are sporadic, but there are a small minority that are related to genetics. And part of a good medical history from the doctors taking care of these patients is to explore with them, are there other people in the family who've had kidney cancers or other cancers, and try to see whether or not there are these linkages that might be there. Because occasionally we will find a genetic linkage, and that might have implications for members in the family in terms of testing that might need to be done, which would be a different recommendation than the routine population. Most of the time what happens in kidney cancer or other cancers, if they're inherited, is we have a problem with what is called a tumor suppressor gene. And I'm just going to tell you a little bit about that. The computer says we're going to run out of power. Just to let you know. So a tumor suppressor genes, like the name implies, are genes that repress growth. So think about it like your car. You've got a brake and you've got an accelerator. And when you're driving in a controlled fashion, it's a delicate balance. How much I put my foot on the gas, how much I put my foot on the brake. And when you have genes in cancer, you've got genes that make things go forward, which are called oncogenes, and genes that are negative called tumor suppressor genes. As a tumor suppressor gene is active, it slows things down and stops that uncontrolled growth. So you can imagine if you lost all of your tumor suppressor genes, it's the equivalent of taking your foot off the brake at a red light. Even though you don't put your foot on the gas, you'll roll forward. So if we lose all of these negative repressors on growth, the cancer cell will have that ability to start to grow. Now you have 2 copies of any one of these tumor suppressor genes in your body. One came from mom and one came from dad. And they're so important to you that all you really need is one that works, and you're okay. So if you happen to be born with 2 normal copies and then through just bad luck over the course of your life, you lose those 2 normal copies, eventually that cell will start to grow, and that's what can lead to the development of cancer. However, it is also possible that if your family has a genetic problem, that one of the copies of that tumor suppressor gene is broken. You may start life off with only 1 good copy and 1 abnormal copy, and that's the difference. So if you have 2 good copies, a lot of life events have to happen to you over time to wipe them both out and lead to cancer. But if you start off life with only half the normal copies of these tumor suppressor genes, then you're in trouble, because you're going to find out that your tumor suppressor genes are going to run out on you earlier in life than you had anticipated. So instead of getting cancer when you're 60, you're going to get your cancer when you're 25. And you're also going to find that all of those cells in your body were similarly affected from when you were born, so you might develop multiple cancers. And that's why some of these inherited cancers happen in both kidneys at the same time. And people, when they're diagnosed, may end up having a CT scan that shows they've got 2 tumors in one kidney and 3 in another. So that's why when we see genetic stories that make us worried, the people who have genetic linkages are often people with cancers at a younger age, multiple organs, and a strong family history. And so those are the things that make the alarm bells go off in a clinician's head, as opposed to the sporadic cancer, where you find out that there really isn't anybody else in the family who had it, and grandma had kidney cancer when she was 70, and it was only in 1 kidney. So that's the difference between inherited and sporadic, and basically it's because of an abnormality of these tumor suppressor genes. And this is the same whether it's kidney cancer, breast cancer, colon cancer. And we've identified more and more of these genes in kidney cancer, and that has helped us to make diagnoses, but it's also helped us to target the problem. And that's been what has been the big revolution for us in the new treatments that we have developed. So that's the basic difference between sporadic and inherited. All right. think we're close. Perfect. I can see it anyways. So metastasis. What is metastasis? Well, that's simply the definition of whether or not the cancer has spread to a different part of the body other than the kidney. It can go to distant organs in the body, and the most common spot that I mentioned is lung, but it can go to other parts of the body as well. And if it goes to other parts of the body, it means, unfortunately, in most cases, it can't be cured, but that doesn't mean it can't be treated. Okay, that's an important difference. People believe sometimes that there's no point, or why would I go to the cancer clinic, or what can they offer me if this thing is spread and I can't be cured? Not being cured is not the same as not being treated. It's an important difference, and that's something that I think is a very important takeaway message. Now, the last thing I want to talk about briefly is complementary and alternative therapy, because we know that you're on these medications, even if you don't tell us. Surveys of cancer patients have shown that for different kinds of cancers, it could be as many as 2/3 to 3/4 of people are taking something that is considered to be complementary or alternative that isn't what we consider Western medicine, and I use that in quotation marks. It can be done at any time in the disease trajectory. It may be done as an adjunct to things that have been already performed, such as surgery, and it's an empowering thing for people to take control. They feel that they are actively contributing to their care plan, and I can't argue with that whatsoever. And the thing are concerned about is combining these things together with the conventional treatments that we give. Complementary therapy may be considered to be natural, but natural compounds still have to be broken down by your body and can put stress on different organ systems. And they can interact with medications that are being prescribed or other treatments that are being administered. So we have to use a bit of caution, because the problem I have is that if you're on a new complementary therapy, it's never been tested with maybe the medication I'm recommending, and that might mean lack of efficacy or more side effects. So it's a bit of a buyer beware scenario here, and quite often we'll recommend, if we're on conventional therapy, minimizing the use of complementary therapy just to reduce the risk of these interactions. However, most important thing is, please tell us. We won't be mad, we won't laugh, we won't belittle you. We really want to know, because you might find that some funny side effect is occurring, or you're getting an adverse event occurring to the patient's health, and if you don't know the whole picture, then we can't help you in decision making. So your doctors and nursing staff and other caregivers really do want to know everything that you're doing. So my final take-home points. RCC is a cancer that's actually increasing in frequency, but it's relatively a small player in the cancer world, which is why we need to continue to work together. Most of these cancers are found incidentally because you've had a CT scan or an ultrasound, but you may have blood in your urine as an initial sign. And for us to put together a treatment plan with you, we need to know all about that histology, the grade, and the stage. Most of these are not inherited, and there are sort of triggers, as I mentioned, that might make us think that way. Most of the time it really is a bad luck scenario. And while many people will be cured, it can spread to different organ sites, but that doesn't mean it can't be treated. And I think the most important message I can say to you is be an advocate for yourself. You know, you're going to have to be the most, this cancer diagnosis as a patient, you're the one that it matters most to. So, be an advocate, be involved, and certainly work together with your care team on your plan to wellness. Thanks.